So I'm going to talk about the 6-week check. I'm not going to go through the basics of an examination, but I'm going to emphasise some of the things that I see that miss through, that fall through the cracks, some of the things that develop in the later neonatal period, and a few other things to think about. We've heard a little bit about screening. I think the 6-week check is really important because it's the last phase of our newborn screening program in the country. And with services being stressed and staff issues, there are things that fall through. So it's important both as GPs that this will be the first meeting with the baby often, but also to think about the whole process beginning from the fetal phase. Emma's talked about the MST, morphology screening, what happens in the newborn period. We have 3 formal neonatal screening programs in the country, so the MST, the Guthrie card and hearing, but the other components, transitional monitoring with news, lactate pulse oximetry, and the week 1 examination. I'm not entirely sure how often they happen, so it's important that you check that. The 6-week check is not just about doing a baby examination. It's important to review the perinatal history, to look for issues that might need ongoing care, to think about growth and nutrition, and I'll talk about that. Continue to promote safe sleeping, think about maternal wellbeing, and ensure that the first vaccination is completed. Last month at Counties Manukau, we phased out the baby blue card, which you may have come across in your training. This was no longer fit for purpose in terms of information, but also we now have electronic care systems. So we've released this neonatal summary, which you can see on the screen. Hopefully that is coming out to you electronically, and it should be delivered to your inboxes within the first 24 hours. And it covers all the information that's shown there in the green box. We're working hard to make sure that that's complete. And I hope it's useful, but if you have any feedback, I'd be very happy to receive it. Just a couple of points about vaccinations. You'll be familiar with the standard schedule. There are a few things to think about for preterm babies. So in terms of pneumococcal prevention for extremely preterm babies, we use Prevnar, which is PCV 13, which is different to the schedule, which is PCV 10. And these babies should receive 4 doses, so it includes the 3-month vaccination, which they won't get in the routine schedule. For preterm babies who have had severe bronchopulmonary dysplasia, so that's having oxygen of 30% or more at 36 weeks or been on CPAP or high flow, these babies should get influenza vaccination from 6 months. They need 2 doses, and hopefully that's going in our discharge summaries as a recommendation. Finally, after many, many years, we finally got RSV prophylaxis funded in New Zealand. So we now have access to the monoclonal antibody to prevent RSV, and this is available for all babies under 28 weeks or babies under 32 weeks if you have BPD or your Maori or Pacifica. And these are delivered by public health nurses, and it should be happening automatic, but it's good to ask the parents if they've actually received it. I'm just going to talk now a little bit about growth. It's important to identify whether a baby was born with growth restriction, because only half of them will be picked up during pregnancy. We have a new guideline that will be released nationally very soon, and this is the definition that will be used. The most important thing about detecting fetal growth restriction is to have a customised birth weight, which is routine on our electronic neonatal summaries. So a baby will be growth restricted if they have a customised centile less than 3. If they have a customised centile that's 3 to 9, which we would have previously called SGA, and they have 2 additional features that support growth restriction, those ones listed, then they'll also be diagnosed with FGR. It is possible that babies can be growth restricted in the normal birth weight range, and we see that particularly with Pacifica. So if you're above the 10th centile, but you have been diagnosed antenatally and you have abnormal Dopplers, then that confirms a diagnosis as well. Identifying growth restriction is important for several reasons. Internationally, it's now recommended that these babies should commence blood pressure screening from age 3. It's also important in terms of the baby's growth and nutrition. So just a little bit on growth. These are average values there that you would expect to see from 6 weeks. So weight gain of 150 to 200 grams a week, length increasing by 1 centimetre and head circumference by 0.5 centimetre. It's also important not to just think about the gains, but the quality of that growth and proportionality. BMI is really important, not just in childhood and adulthood, but also for neonates. In our population in Auckland, the mean birth weight for mean BMI for healthy, uncomplicated pregnancies is 13 for the babies, and by 5 months, you reach a peak of about 17. It's important to think about that because often the message that we need to give is actually a baby is growing just fine and they don't need to be bigger. And certainly babies who are on a very high BMI trajectory will likely continue that through childhood. The other issue you might face is slow growth, so that's less than 100 grams per week. Usually that's due to difficulties with lactogenesis or feeding, latching. It's really important. It's tempting to give formula because that will fix the problem from the baby's point of view, but if we're trying to support mums for breastfeeding, we really want to hold off on using formula, and I'll encourage you to refer to one of the community resources to support breastfeeding. If it persists and lactation is good, then I would commence those first-line investigations listed there. In my practice, I often see occult UTIs as a cause of failure to thrive, so it's important to think about doing a catheter urine. I was going to talk about ferrous sulfate and vitamin D supplementation because I was asked to do that. Our rates of deficiency in children, infants with iron and vitamin D are really high, so it's important that we're proactive in thinking about that. Firstly, iron deficiency. About 1 in 6 Maori and Pacifica infants in South Auckland are iron deficient. That has many consequences for their health, not just for anemia and increasing the risk of pneumonia, but also it can have long-term permanent effects on their cognitive and motor development, behaviour, and has also been shown to have effects on their sleep architecture. While it normally presents from 4 months, we need to think about it early to prevent it. And that prevention is important because the effects on development and sleep may persist throughout childhood, even after correction. The main risk factors for iron deficiency are preterm birth and fetal growth restriction. There's about a 9 to 10-fold increased likelihood for those infants. The big pregnancy risk factor is maternal iron deficiency. And unfortunately, breastfeeding is good for many things, but not as a source of iron. So babies who are exclusively breastfeeding are at high risk, and I've talked about the ethnic association. What can we do to prevent it? Well, if a mother's planning to breastfeed and there are any other risks, then we should be providing delayed cord clamping. That helps somewhat. We should be supplementing all preterm babies and those who have fetal growth restriction, including those that are above the 10th centile, with ferrous sulfate, 2 to 3 milligrams per kilo per day. And that can start from 2 weeks and should continue to about 9 months, basically until a baby is well established on solids as the primary nutrition. Breastfeeding is controversial. Internationally, it's recommended that all breastfeeding mothers have iron supplementation for their infants. As a minimum, we need to ensure that those mothers are iron replete, and it's important to start iron-rich foods for breastfeeding infants by 5 months. If there are other risk factors, then I would start supplementation, and this can start from 6 weeks. We still see cow's milk being given to infants, so it's just important to reiterate the message that cow's milk should not be given before 1 year of age. And if we're proactive about supplementation, we don't need to do routine testing. Vitamin D, in New Zealand we don't have a formal screening for vitamin D in pregnancy. It's targeted. Supplementation is recommended. But despite that, we're still seeing high rates of vitamin D deficiency in women. The mothers who are most at risk have darker skin, those that have limited sun exposure. If you have your 2nd and 3rd trimester in winter or spring, you're going to be much higher risk. For example, in the South Island, if you're below Nelson Marlborough, about 60 to 70% of women will be vitamin B deficient by the end of winter. Maori and Pacifica have higher rates, even if you adjust for other covariates, and of course women who have liver and kidney disease. The consequences for the infants are hypocalcemic seizures, and we see that not infrequently, and rickets. There are also possible effects on language and psychomotor development. The risk factors are pretty much the same as for iron deficiency, so we need to be supplementing all preterm babies, those with growth restriction. The recommendation is to give 400 international units, which is the equivalent of 1 drop of Puria, which is now available in the community. And if a mother is breastfeeding and she has risks herself, or there's been a previously affected sibling, then we should supplement those infants too. It's a good idea, although it's not universally recommended, but I think we should be thinking about supplementing breastfeeding women routinely, and that can be done with the standard capsule once a month. Let's go with that. So I'm just going to go through a couple of things that are difficult sometimes to assess. So red eye reflex is a difficult examination and can sometimes be frustrating, but it's very important to do. It's where you will pick up cataracts, retinoblastoma particularly. When you're doing it, you want to focus your ophthalmoscope on the pupil, and that's about at 30 centimetres, so you want to focus according to your own lens requirements to see that you can see your hand clearly. It's important to look at both eyes equally, and that's a key part of the test, because you want to see that there's a homogeneous orange-red colour that's equal in both eyes, and I'll show some examples of why that's important. You're also thinking about evolving vision, so blindness is not usually detected at birth, it's usually detected at about 4 to 6 weeks. So you want to see that that infant has a really good regard for your face and for objects, and they should be tracking horizontally. And you also want to start thinking about squints. So squints are very common at birth, but by 3 months, basically the visual axis should be well established. You can accept up to 15 degrees of disconjugate gaze, but by 15 months that should have normalised. Just some examples. So on the left, there's a cataract, a typical one at the top with the brown spidery pattern, but it can also be dense and completely eliminate the red reflex. And on the right-hand side is some examples of retinoblastoma, so loss of the red reflex, but you can also get, like in the bottom, leukocoria, which is the loss of red but white reflection. Palates. We should be detecting clefts at birth, but submucous clefts may slip through. So it's really important that you look with the torch and with a spatula and see whether the uvula is present. Dimples, I get lots of questions about that. The main reason that we're interested in sacral dimples is tethering of the cord or occult spina bifida. And the main thing that you're looking for here is whether there's abnormal hairy pattern, whether there's pigmentation of the lower spine, or whether the dimple is deep. So blue spots we don't worry about, simple dimples can be completely ignored, but the ones on the right should have a spinal ultrasound, and that's optimally done before 3 months. Hips can, the approach to hips has changed in recent years. We're less aggressive about investigating and following up. And the main thing is to really identify whether a hip is unstable. It's called developmental dysplasia because it does change. So there are babies who have normal hips at birth but can develop after birth. So that's why all babies should be assessed at 6 weeks. And it's important to remember that most cases actually don't have risk factors. There are 2 manoeuvres. The first one is ortolani, which is when you're trying to relocate a hip. So I think of that as ortolani out, you're abducting. Barlow's, you're trying to press back on an adducted hip, and I think of Barlow bumps back. You don't want to use a lot of force for that. You can actually create laxity with high force, so just gentle manoeuvres. And I think the most important signs in detecting hip, particularly dislocation at 6 weeks, is you should be able to abduct both the knees, completely abduct them onto the mattress, and you also want to look to see that there's normal symmetrical femur length, and the best way to do that is to bend the knees at 90 degrees, put the feet together and see if the knees are at the same level. Obviously if there's positive signs of instability you need to refer. If you just have rubs and clicks and the hips are stable, you can ignore that. And there is a general recommendation in the health pathway to do x-rays at 4 months for infants with risk factors. Somewhat controversial, but I would particularly do that for extended leg breach and if there's a family history. Neurology, we would pick up most severe neuromuscular disorders at birth. We'll pick up strokes, we'll pick up neonatal epilepsy syndromes. But the things that may evolve in the later neonatal period is central hypertonia, so things like Prader-Willi. I'm not quite sure why neonatal reflexes have such an emphasis in our teaching, but they really have only entertainment value. The most important thing is to assess truncal tone, particularly at 6 weeks. And so if you put a baby prone, they should be able to lift their chin, as shown in the cartoon. And if you hold them in ventral suspension, they should be lifting their buttocks and their head up, like in the baby that's shown there. If you hold them under their armpits, they should actually be taking fully their weight. And so for me, that's the important thing that you need to focus on is truncal tone. And the other thing that's really important at 6 weeks is the baby should look at you with purpose. And I think that's probably the most important neurological sign. So if they're not looking at you and communicating with you, then often something is wrong. That can be status, non-accidental injury, and a range of other things. So we would pick up a lot of seizures early on, but the thing that you'll probably get is myoclonus. So these are just some examples of benign myoclonus. And a baby who's thriving is otherwise well, you don't need to worry about these kind of abnormal movements. What you do want to identify is the baby with infantile spasms, and the sooner that we can identify these babies early, the sooner we can get them investigated and start treatment. And the main thing is these babies get distressed with infantile spasms, they're sudden extension and release movements. Good. The last thing I'm going to do is just talk about rashes. So you'll probably get lots of questions about pustular rashes. There are a number of benign ones that you can ignore. So the one on the left is neonatal pustular melanosis, where you get these watery pustules. There's no inflammation. They rub off easily, and then you get a pigmented base. They typically start in the first week, and they can continue up to 2 to 3 months. And then the ones on the right you'll be familiar with, neonatal acne and prickly heat. And this is different from folliculitis, which is more aggressive. It's golden, crusted, particularly focuses on the creases in the groin and the neck. And these need antibiotic treatment. And lastly, when you're thinking about the skin, there are a few conditions that you'll see probably once or twice in your career, but it's helpful if they can be recognised and referred early. So particularly in more pigmented babies, if you see pale macules, they can be ash leaf spots, which is a sign of tuberous sclerosis. And then on less pigmented children, you'll see cafe au lait spots readily, and that can be a sign of neurofibromatosis 1 or other neuroendocrine conditions. And that's the end. Thank you.